Thank you and welcome. And good afternoon to most everybody. I'm so glad that you could join us today. We're here live at the Hart House in Washington, D.C. So being live is always interesting, but it allows everybody the opportunity to ask myself and my esteemed colleagues any questions that you may have. And I'd like to thank you for joining. This is our second Heart Talk, and we had such a good time doing our dyad, and I'm hoping that this one, which will be equally important to us, and we need to have really candid conversations as it involves both equity and access to health care. I think the pandemic really taught us something, and actually it highlighted an ongoing issue that we have with access, not only in our country, but also internationally and globally. And that's why I'm thrilled that being here live with me today are my esteemed colleagues, Dr. Paul Douglas and Dr. Antonio Chagas. Those of you that may not know, Dr. Douglas is our current chair of our task force on equity, and I'm thrilled that this will become a committee. As we go through our nominating committee process this year, the board has felt that this topic is so important that it's actually going to become a committee, and you will be our inaugural chair, which is amazing. And Dr. Chagas, you've done just a wonderful job internationally with Brazil and all of your fellow colleagues. And the one thing I've learned as we've been around globally is access is really, truly an issue everywhere, not just in the United States. And our examples of inequities really are many. A recent JACC report card found that Black Americans, because of their higher cardiovascular mortality rate compared with white Americans, have suffered almost 800,000 excessive deaths, which translates to about 24 million additional years of life lost between 2000 and 2022. Dr. Douglas, that just is an astounding number to me. And I know you have worked so tirelessly in this field. What were your thoughts when you saw that report card?
Well, unfortunately, Cathie, this is not new to me. We have to understand the root cause of the inequities and the disparities that we see. Having grown up in the South, unfortunately, I've seen those up close and personal. And so that was not too surprising to me. Over the last few decades, we have all come to acknowledge the fact that disparities in care does exist and that it does result in lost years of life and excessive mortality. And so I was not surprised at those statistics. It's nice to see us document those things. And now our real challenge is, what are the solutions? How do we make those types of disparities either be lessened or eliminated?
Eliminated would be great, wouldn't it?
Right.
And I know our Board of Governors, as we refer to them, our BOG, also had a very active discussion this week on their listserv, because another study that was just published in JACC found nearly half, that's 50% of our counties in the United States have no cardiologist. That to me was just a mind-numbing acknowledgement, and that the prevalence of CV risk factors and mortality are just amazing in many of our own counties within the country. And this isn't just in the US. Globally, factors such as geography, political conflict, and poverty play major roles. Antonio, you probably see this a lot as both in your role as AIG chair, but also as you travel globally. What are you seeing?
Yes, President Cathie Biga, Professor Paul Douglas, it's a privilege to talk to all our friends around the world and here in Washington, D.C. Of course, that the same questions and the same problems that we have here in the U.S., we are having globally. And I can say that probably we have more problems than you have here in the U.S. Because, of course, that you have a problem because of the capacity to work, because of the power of the several countries. And also we need to remember that you do not have the same amount of money to take care of health. And we have around the world some problem that's the cardiovascular disease and the incidence of cardiovascular disease. But of course that you continue to have a high mortality around the world, that this mortality is similar in some countries higher than in the US. That means that we need to do a lot in order to make this difference smaller, and also to have our cardiologists trained in order to have good results in order to prevent cardiovascular disease around the world.
So as we try to shed light on this critical topic and how we actually define it, what the challenges are, because that's what we need before we get to solutions, is to make sure that we understand this. So Dr. Douglas, how would you define equitable access? What does that really mean to our audience, not only to our physicians, but our CV team members?
Well, and I think that this is an important point to make, and that is equitable access, in my mind, means that every patient wakes up with the knowledge that healthcare is a right, not a privilege, and that they will have the opportunity to engage or have a health encounter that is provided by a culturally competent caregiver in a health environment that is supportive and sensitive to their needs, and will be able to provide them with, most importantly, preventive and primordial prevention strategies, provide them with the care that they need at the right time and at the right place. And if that care environment is not the right place, that it's easy for them to get to the appropriate facility that can provide them with the needs that they have. And so I think it's important that people feel that that is a human right, and it's part of our responsibility to ensure that right.
And how close to that do you think we are? I mean, we're certainly not in a perfect world. Do you think we're educating our fellows and our nurses and our CV team? Do we need to start there, or what would be a good solution? Because one of the things we like to do during these Heart Talks is give actionable solutions that our teams can use. So what would be one of your suggestions?
Well, one of the things I think that is important is that as we embed health equity principles into everything that we do in the college, that the educational piece, which is so important to the ACC, that health equity is embedded in that educational process, that we teach our fellows, that we teach our faculty the importance of health equity. And that should be a competence that everyone tries to achieve, and that it is not a luxury, it's mandatory. This is part of your learning process, and it's something that is important, that's going to improve and impact the health outcome of the individual that's in front of you.
Because I know we talk about not just necessarily prolonging life and having long life expectancy, but a healthy life, because a healthy life is so important. So Dr. Chagas, what do you see? We have, 42 international chapters, and so we've got at least 42 different ways of how we educate our physicians and our CV team. What do you see globally that would help us get to a educational process that would help with this?
This is very important. For example, I completely agree that health is not a privilege, it's really a right. And us at the American College of Cardiology around the world, we are trying to modify the quality of care and the quality of attendance of patients around the world. For example, we have 42 chapters around the world in the 5 continents. Our presence is universally. But we started a very important program called GATI. The Global Heart Attack Treatment Initiative was developed under our Assembly of International Governors. This was in 2019, and the eyes was to improve acute myocardial infarction care for patients for an institution in low to middle income country. Can you imagine that now we have more than 10,000 patients that was reached from our program? And this was very important because we were able to decide to receive quarterly reports on quality, on metrics, and data points, also to see the performance and the quality of care. And with that, we are able to train people. We are very interested to train not only the physician, but also all the people, the nurses, the pharmacists, the social work, everybody, because now we need to remember that treatment needs to be multi-professional. This is one of the initiatives. But you have another one that's very important. We are doing programs that the observership, the physician from the power countries, from the low-income countries, come to the US. And here in the US, they have a period of training here to improve his knowledge and also to come back to his country and to be also a leader of this treatment, of a leader of this initiative. This is two very important things because, as you need to remember, health systems are often not designed for the aging people, that you have a lot of aging people now, for urban populations, and also for rural populations that has a lot around the world, specifically in the low-income countries.
So you talk about Gaudi, and Gaudi is such an important initiative that the college started long ago. I think Dr. Cesar Herrera and Hadley Wilson, our immediate past president, were very involved in that. And Paul, as we sort of look at the Gaudi data, how amazing would it be to use our Gaudi data and our NCDR data to really help us identify where we may have both access issues or inequality issues? Do you think we can really use our quality data as a roadmap?
Well, I think we have to. I mean, I think that for too long, we have ignored the realities that are right in front of us. And so we're trying to implement these tools and utilize these tools that help us to identify the areas of highest vulnerability so that we can allocate resources to those areas. And that works both in a national view of things as well as an international view of things, so that these disparities in care can be identified based on the demographics of a particular country, and then we apply the resources that we have to try to meet the needs of those vulnerable populations.
And I think the observership that Antonio talked about is also so very important because we can learn so much from each other. Because I think whether I'm in Chicago or whether I'm in Atlanta, we still have healthcare deserts. And I think it's something that is so important for us to identify. So one of my questions is, we talk a lot about the shortage of cardiology. We just identified that we have maybe almost half of our counties that don't even have a cardiologist. What about our CV team? How can they help us with access? What are you seeing in your day job, as I like to say, as relates to using your team?
Absolutely. And I think that one of the things that we have to recognize is the fact that we are in a workforce crisis. And the question is, how do you deal with that? And at that point, I think the cardiovascular team becomes extremely important, that we utilize the resources that we have, that we understand that we have people practicing at the top of the scope of their practices, and that they help us to care for those vulnerable populations. And so one of the ways I think that we can deal with the workforce crisis that we are being confronted with is that we utilize all of the knowledge and the abilities of the people who are working with us. And so the cardiovascular team and the team approach becomes an imperative. I think that that's the way that we work our way out of this challenge that we're confronting.
And I think that is really an identifiable barrier for us because, and it's not really just our nurses and our APPs, but also our pharmacists and our dietitians. And I know when I was in Brazil, we talked a lot about this. And I think when we have the Brazilian meeting, we're also going to involve our team much more inclusively. And I think if we can get that message across, globally, would be such an important part. But now it's your turn out there. We need some questions so that we can understand a little bit better what you're facing in reality. Because one of the other questions I have, and I think this is the right panel to talk about it, is where should we be delivering this care? Should we be going to where our patients are, or because we're in this workforce shortage, should we ask our patients to come to us? What is the reality of our patients that may have cultural or language barriers? How can we encourage them, and where should we be delivering this care?
Well, I think that too is a very important opportunity for us to innovate. And I think that the COVID pandemic forced us to look at how do we better remove the barriers that patients have in terms of transportation, getting to us, getting the education that they need to better care for themselves. And so telehealth really provides us with a tool that helps us to bridge that divide. And I think that as we look at how we best do this, that maybe we can care for people in their homes, and maybe utilizing tools that allow us to monitor people wherever they are becomes a very valuable resource. And so I think that our days and our finances are not going to allow us to continue to build large glass towers for people who may not need certain levels of complexity of care. That care may be better delivered in the home or in a community clinic, the best place based on what your needs are, rather than trying to provide partner care for everybody.
Yeah, and that's so important. We talk about that access to care, and I talk about not only our vulnerable populations, but our chronically ill patients, our heart failure patients, our AFib patients that are so in need of that team approach. Antonio, I know you're working on something in Brazil that, you know, when you think about the number of people that we have on our catchment areas, what are some of the things that you're working in Brazil to make sure that no matter where you live, that you're able to get good STEMI care, even just good STEMI care?
Yes, that's very important. As Professor Douglas talked, we need to remember that the pandemic led to us a very important access, that is the technology. But we have a big lack of integration for innovative technology to the use of that. But for example, our country, Brazil, as everybody knows, is a very large country. And with this technology, with artificial intelligence, and also with all sessions, for example, to training people with a webinar, we are able to promote actions of health, because we need to work in chronic disease and also in primary disease much more in prevention than in the treatment. Because always in all the countries, and specifically the middle and the low-income countries, we have a difficulty in terms of resources for that. But using the technology and training our physicians and training our cardiovascular team is very important, Professor Douglas, what you talk about the team. The cardiology team is something very important, but we also need to improve the team with the social works, with the nurse who goes to the frontier, who goes to several places outside the hospital, outside the big centers, because it's the way to promote conditions of health, for example, to quit smoking, to take care of hypertension, to deliver the good food, because we need to use much more our research in prevention than to use that to treat the acute phase of the disease.
Well, and I think the use of AI is a very fascinating topic to talk about, and I would welcome input from our audience as well, because even as we talk about telehealth, you know, Paul, we sort of look at some of our vulnerable populations, we look at our low and middle income countries, and do we even have internet access? Much less can we really utilize AI. You know, how, maybe the better question is, how can we utilize AI to facilitate that care of our patients and make it easy? If we can't get telehealth made easy, what can we do? Because we need to talk about some solutions.
Well, I mean, and you raised a very important point, Cathie, and that is we can't do this alone. This is a societal problem.
Yes.
We have to be advocates and strong advocates to allow us and help us to deliver high quality care for our populations. But at the same time, we need, as an example, government intervention to be sure that people have adequate access to the internet. That if you live in a home where there is no internet access, your ability to live a fruitful life is compromised. And so that becomes a societal issue. And that's, I think, is important. And as we talk about potential solutions, we realize that the healthcare industry can't do this alone, that we have to collaborate with other partners in our society, government, our industry partners, community-based organizations, that this is really has to be a societal effort. We can lead the way, and as well as we want to, and we have the responsibility to, but at the same time, it's going to require tremendous collaboration in order to achieve the goals that we're trying to set.
Well, and I think you teed that up perfectly with advocacy. And advocacy, not just in the United States, and I noticed on the slides ahead of time, we talked about our Ledge Conference, but the one thing that has amazed me is advocacy is critical in every single country. It doesn't matter where we live. We have got to get the government to understand and to help us. And I think you're working with that with Gotti as well, as we sort of realize that we can't do that. We can lead it, but we can't do it alone. So what do you think about advocacy?
Now, first, I really wanted to thank you for in your recent visit to Brazil in São Paulo. We had a fantastic conversation with the municipality of São Paulo. You are the main person of the talk. And this was fantastic because we were able to start a new area of Gatti, specifically in São Paulo city, where we will take care of a large number of municipalities, hospitals, with the internet, with the service, and with the care of the acute myocardial infarction. And this will be very important also for us internationally, because with this example, this spot in Brazil, in São Paulo, we can do the same in countries like India or like China, where you have a large community, a large number of patients. And I really assume that we will have a great challenge for this project in São Paulo, but at the same time, you have a fantastic opportunity. And as Dr. Douglas talked, we need to ask the government, we need to ask the politician, we need really to ask the persons who are responsible for the community, because it's the only way to have the solutions of these big problems of cardiovascular disease and cardiovascular care around the world.
So I know a lot of you have got to have some questions for us, or even maybe some help for us. What are you doing in your communities that really help us to achieve this? So feel free, if you'd like to come live with us, just put it in the chat and the team will take care of you. But one of the other issues that I want to talk about a little bit is, as your health equity task force, now committee, what would you think the top 1 or 2 actionable items are that you've been working through and with that you'd like to see come to fruition?
Well, there are a couple of things I think that they're fundamental that I have to preface my response with. One is, I think that we really have to understand the root cause of the disparities that we're confronting. And I think that we have to accept the fact that there is a legacy of systemic racism and inequality that has haunted our country. So we have to acknowledge that and then move forward. And so,
and you don't think we've acknowledged it yet? You think we have a way to go?
I think that we keep talking about it, and we keep analyzing it, and we are coming up with wonderful ways to capture data. But the time now is for solutions.
Right.
You know, I think that, you know, there was, you know, when we got the Heckler report in '85, it was eye-opening. And then the Institute of Medicine report in 2002, that was a compendium of scientific data that showed and proved that these disparities did exist, and that the consequence of those disparities was lost life, excess mortality, and lives lost. So, I mean, I think we have spent 40 years collecting data.
Time to act.
It's time to act. And so that's one of the things I think that our task force did. First off, is we had to accept the fact that we understood the root cause of the problem. And then we had to decide, how do we come up with domains that we can leverage the resources of the American College of Cardiology through, that allows us to deal and implement solutions that can make a difference. And how does that equate into our ability to achieve that quadruple aim that we're all trying to achieve in healthcare. And so we've done those things, and there are a lot of things, you know, that we have put on the plate. And I think advocacy is top. It's one of our highest priorities, primarily because of the ability for the government, particularly the government, to impact health outcomes with almost with the signing of a bill or the flip of a switch. Tremendous resources can be applied to identified vulnerabilities that can make a difference overnight almost. And there are many examples of that where government has stepped in and we have really made a difference. Prevention of smoking, you know, our ability to extend Medicare to the elderly. Those are things that change the lives of people and improve long-term outcomes. And so we want to take our contemporary problems that we see now and continue to advocate our government to apply those lessons learned to the challenges of today.
Well, and I think prevention is so very, very important and something that I think we can talk about. But one of my long-term heroes is online, Thad Waits, who has been a huge advocate and has done so much both for his patients and the college. Thad, do you have some thoughts to share with us? Whoops, we can't hear him.
You muted that.
Okay, I think I got it
There you are.
unmuted. Yeah, thank you. I was saying I have a brand new iPhone that I hadn't quite learned all the tricks on yet.
You need those
So
grandkids.
there you are. So hello, dear friends. Paul and I go back all the way to training with each other, and Dr. Chagas and I have known each other for several years. And Cathie, I love you much, and you're doing a wonderful job. I wanted to suggest to you what we have done in the state of Mississippi. I am on the health board in Mississippi, and we have started a program of using Lyft and Uber to get our patients to the medical facilities. We were spending so much money just moving nurse practitioners around and seeing one patient here and one patient there, that we now have set up central locations. It's in the early stages of it, and now we're doing Uber and Lyft with very good success. So I wanted to do that suggestion for us, and Paul will be talking about that tomorrow, I'm sure. But the question I have for us, community health workers, and just what your thoughts are, all three of your thoughts are, of what we can do with community health workers. We're trying to get a credential program for them in my state. And in fact, we already have a program now where we're paying them reasonably good salaries to do a lot of the work that we just can't do without them. And I'd love to hear your thoughts on that.
I think the Uber Lyft is a great resource for many of our, and actually international as well.
Fantastic idea.
Yeah, it really is. But I think you have tapped a resource of our community workers that usually have such a passion for their communities and such a desire to elevate many, many things, you know, healthy food, healthcare, all those types of things. How can we engage them better? Any ideas on how we might be able to engage them better?
Well, I think that one of the things that we should do, and thank you, Thad, for those comments, because I think that collaboration is key to our success. Our ability to identify community resources that help us to care for those vulnerable populations is key. The people who understand the problem the best are those folks who are closest to it. And those community-based organizations and community medical centers know their populations well. They need the resources that those of us who may be at arm's length can provide. And so if transportation is an issue, that offers a reasonable solution to that, something that we should model and try. If getting prevention strategies into the community, those people know where do you go? Which church do you go to? Which barber shop, beauty shop? Where do we apply those resources? And the ACC has a wonderful tool that we've created that looks at this from a zip code standpoint, that we can identify vulnerabilities and create a vulnerability index that allows us to overlap other data sets that allow us to say, well, here's where the problem is, and this is where we should utilize our resources. And so, I mean, we're developing those tools, I think, that help us to deal with these problems. And it is community-based, and Thad is absolutely right, that's where the problem is, and those are the people that we need to collaborate with.
Yes.
Well, and I think prevention, it's becoming a hot spot with me right now, and especially as we sort of talk about what's necessary for equitable access. Because if we just think of the simple, hypertension, diabetes, obesity, you know, and smoking.
Smoking.
Can't forget smoking. And how we have probably half of the Americans that probably don't know their blood pressure. And yet such a very simple thing to do as to how we do that. And I know tomorrow we have our big industry meeting, and there's a very interesting question about whether there's opportunities out there for other partners, not only our clinicians and our CV team, but also our NGOs or industry. You know, how can they help us in this access issue? Because I know as we even look at structural components and whether or not we actually have disparities of care of who can get a TAVR, for instance, and who can't just because of their zip code or analysis. How do we address that?
First of all, I think that we need to insist in the community work. I completely agree that we need to use the community around the world. If the people go to the church, if the people go to this, for example, in Brazil, to the soccer, if the people go to the activity, and now we can have the community together work in terms of prevention. But of course, Cathie, we can use the other resources, not only the government resource, but you can have some funding from industries, you can have some funding for some corporation that can help us in order to promote healthcare. This is a big challenge, but I think that's possible. We need to work on that.
Because we have to educate.
You're absolutely right, but I can't let you get past this point, and that is workforce diversity helps you in terms of your credibility in the community. People have better outcomes when they're cared for people who are culturally sensitive, who share their values,
Yes.
And look like them. And that is scientifically proven. And so our ability to, and we're working on that, to increase the diversity of our workforce, I think is extremely important and is a critical aspect of this. Now that as we go into these vulnerable communities, that we send people that share their values and that they identify with, and they're much more likely to be compliant. They're much more likely to understand the subtleties of the message that we're going to send. And they're much more likely to believe the message when it comes from a trusted voice.
So help me as an administrator, you know, that dreaded administrator. And as I try to ensure equitable access to care, my care team isn't necessarily as culturally diverse or ethnically diverse or even language diverse as my patient population. So what tools, what kind of training can we offer? Let me ask it a different way. Is it possible to train if we can't get a care team that really can look like and come from the actual neighborhoods? What are the other options that we might have from an educational perspective?
No, and that's why I use the term cultural competence. Because you may not be the same ethnicity or come from the same geographic area, but you have to have the responsibility. When it goes back to the educational piece, that as we're educating people to care for other people, that we need to educate them in a way that they're prepared to care for the person that's going to be in front of them. And so you don't have to be congruent in terms of the ethnicity, but you do have to have the cultural background. You have to understand the values of the person that you have the responsibility for caring.
In this particular way, we had a very important government, the American College of Cardiology International, is the NCD Academy. This was launched in 2020. We have a funding from some company and also support from the NCD Alliance and the World Heart Federation. This is designed to equip the global primary care community, such as nurses, pharmacists, and primary care physicians, with the skills necessary to mitigate today's leading causes of non-communicable disease and also to take care of the risk factors of cardiovascular disease. Is like Professor told us, is putting together the intelligence, put together the knowledge to the population in the same way to have good results. We need to live it, to bring the care. For example, the use of zip code is fantastic. It's really fantastic. I need to congratulate the idea.
Well, and maybe we can get the word out about the NCD Academy because it
Yeah.
is so very important. And initially, when I first learned about it, I thought it was just for international colleagues. But
No.
if you think about it, the United Nations has a very aggressive NCD work that
Mhm.
needs to happen. And it is such an important vehicle.
I have some numbers from NCD Academy.
Okay, sure.
We have now 25,000 people spending in 147 countries.
147.
Yes,
Wow.
That's
yeah,
amazing.
it's
Very-
amazing.
So, and of our international people,
Yes,
that's really,
yes,
really going to
yes.
be important. So we have a question, and this is probably coming back to that nuts and bolts of real actionable data. How can we better train, starting with medical students and maybe
Yes.
even before that?
Yeah.
But how do we train our medical students, our residents and our fellows about health equity? Because like most of our non-clinical competencies, it's not embedded in
No.
the fabric of our educational system yet. So what do we say to our program directors and internationally? Where do we start?
Well, I think we have to start with the curriculum that we're developing. That as you develop your curriculum, that health equity becomes as important as giving the right drug or putting the right stent in. That is a key component to your educational process. And I think that we just need to underscore the importance of that. It is not a luxury.
It's a
If
necessity.
you're going to improve cardiovascular
Mhm.
outcomes, this is what you need to know in order to best care for these populations and every population.
Well, then maybe it really is all about everyone, our care team, our physicians, personalizing medicine to the individual. So there's social determinants of health that we've heard so much about. Really, as we're doing our treatment plans, each element has to be taken into account: where they live, how educated are they, what's their financial status? Because if I give them my heart failure regime and they can't afford it, or they can't get to a pharmacy to purchase it, what good is it?
Absolutely, absolutely. And those social determinants of health, you know, and we've talked about this a lot, and we will highlight this in our action plan that will be published later
Soon.
this month. I have to shameless plug, in Jack Advances, the end of the month will be the action plan from the Health Equity Task Force. And in that, we talk about the fact that the health cardiovascular outcome is about 20% is dependent
Right.
upon your encounter. 80% of the outcomes are based on those social determinants of health. You know, can you get to the care facility? Is transportation an issue? Do you have healthy foods available in your neighborhoods? Is your neighborhood safe? Can you do you have health literacy? Can you understand what the information represents? And so those are things, and those are societal problems. You know, we're not going to solve all of those problems. We have to collaborate with our partners in government, and that's goes back to the advocacy piece. But those are the things that we have to deal with as a society. But we have to lead the way because we have the capability of leading. And we have the knowledge that allows us to lead effectively.
Well, and I think the college is so fortunate because we also have the ability and the alignment with MACC, which, as we all know, is an incredible knowledge source that really can help us with the non-clinical competencies, both internationally and within the country as well. And I do see one more question before we wrap up in a minute. So how can technology and digital health innovations bridge the gap in underserved communities? And are there examples? I'm just going to go back one more time because I see this in my own day job is we have all these answers, but yet these answers require resources that many of my underserved communities and my underrepresented individuals just can't afford and don't understand. So while I think there are certainly a fair number of, I mean, telehealth's a great one, all of the digital remote patient monitoring that we have, but it requires, to your point, some health literacy. It requires people to understand what we're trying to do. So I think one of those answers is really just to try to understand our communities and make sure that our solutions are realistic to the audience. Does that make sense?
No, I agree. And I think that, again, it requires us to identify where the vulnerabilities are so that we can focus on solving the real problem, but not just throwing a blanket answer to a solution that can't be implemented. And so leveraging our resources and applying them to the communities that we're trying to serve, you have to customize it based on where you are and what types of problems you're confronted with.
What an excellent way to wrap up, personalizing what we do every single day. So thank you, Dr. Douglas and Dr. Chagas, for being here and sharing your insights with us. More importantly, thank you to all of you. I know this is the middle of the day, not exactly the most popular time for our physicians, but so appreciate you joining us. And I want to just sort of close on a note with Dr. Martin Luther King, who we all know was just an incredible champion. And here's his quote: "Of all the forms of inequality, injustice in health is the most shocking and inhumane." So our work together to rectify this injustice just cannot be overstated. It's so very important. And I think we've identified from our residents all the way through postgraduate training, it's so important to increase that access for cardiovascular care in order for us to improve heart health for all. And so for those of you that have joined us, it's our second time, but if you'll join me in just raising a toast in keeping with tradition, it is just Coke. We thought rum and Coke, but now we just settled for Coke. So to all of you, to the power of unity, to the power of unity, to the strength in our diversity, and to the relentless pursuit from both the college and MACC in pursuing justice and equity in healthcare. To all of you, thank you for all you do every day. Thank you.
Thank you.
Thank you.